You are the first person to join the conference.
Decatur, this is the South Odd. If you can hear and see okay, just give me a wave. Okay, thanks. Yeah, because we can actually put the spotlights on and then we'll be able to see you really well at the podium. Just a reminder, Decatur, if you have a question at any point, just go up and unmute the microphone and you can ask your question.
All right, guys, let's go ahead and get started. Good morning. You guys are starting to look familiar. I'm Stacy Sotovia. I'm one of the faculty in internal medicine and the director of quality improvement for the Department of Medicine. Welcome to the second half of the year in our patient safety and quality improvement GME curriculum. Today we're going to talk about quality improvement in general, how it's different than research, and talk about some basic quality improvement tools. Who's been part of a quality improvement project? Anybody? One. Okay. Did you use PDSA cycles? Yeah? Okay. So that's a really common tool to use. Anybody with a business background? Nobody. Okay. So another common tool are the Lean Six Sigma methodologies, and we'll touch on that a little bit so that you know what it is. So by the end of this session, I hope to do a couple of things. I hope that you understand the difference between quality improvement and research. We're going to touch on this very briefly. Some of the points might be incredibly obvious to you. With that being said, quality improvement is becoming an increasingly important area of scholarly activity, to the point where maintaining certification in your boards, there's something called maintenance of certification. You guys know what that is? So after you become board certified, you're not done, okay? You have to maintain your certification. Most of that requires some performance improvement measurement, okay? So you basically have to do quality improvement projects. Medicine and family medicine have done this for quite some time. All of the other boards are coming along as well. So there's some element of performance improvement that you have to do to maintain certification. So, and a lot of our residents that are interviewing for fellowships are finding that they're being asked, what kind of quality improvement work have you done for your institution or your organization, rather than what type of research have you done, okay? Especially for those very clinical fellowships. We're going to talk about two common quality improvement methodologies, as I touched on. And then we're going to talk about how you, if we have enough time, we're going to talk about how you change a system, okay? Some strategies for change. So what's the difference between quality improvement and research? Tell me what you know. Same thing? Done the same way? Done for the same reasons? What do you think? How about the time? Which takes longer, quality improvement or research? Good. Okay. We're talking in generalities, right? What's the goal of research? Who's participating in research? Clinical research, basic science research. Okay. What's the goal? Find something new. Fantastic. New knowledge, new procedure, a new skill. It's to create something new, okay? The goal of quality improvement is to apply what we know, okay, in a consistent way. Yeah.
There we go.
Okay. Thanks. So the difference between quality improvement and research are those two basic things. Here's a grid. Research, discover new knowledge. Quality improvement is application of knowledge, okay, and best practice. Tests, in research, you try to eliminate all the confounding variables up front. You try to control for everything. Quality improvement, you acknowledge a lot of those things and those biases, but you move forward anyway. Small cycles of change. Research, you want to have enough data to power the study, okay? You want to have enough data to know that the results that you're getting, you're incredibly confident in. and it's reproducible. In quality improvement, you want to get enough data that you know that you're heading in the right direction. Okay, because that's probably not all the data that you're going to be after. You're going to keep doing small cycles of change and getting more and more data to move things in the right direction. Okay, duration, highly variable with research. Some quality improvement projects will last forever. These are, again, generalities, but there is a difference. With that being said, a lot of quality improvement projects now are requiring IRB approval. Okay, and a lot of what we start out doing a quality improvement project in actually becomes a research project. In medicine, I'm going to show you what we've done with opioid prescriptions, and that's now become a research project. We have 3 grants outstanding for the work that we've started. So this gentleman, Walter Shoehart, any U of I graduates? This is an easy question. 1. Okay, nobody else? This gentleman is from New Canton, Illinois, which is over by Quincy. Walter Shoehart, what is his name? He's a University of Illinois graduate. He was a physicist and a mathematician, ended up being sort of an early statistician, okay? And he had this theory that both pure and applied science are really important. And he was a basic scientist, but said, you know, sometimes applying what we know is more difficult than discovering new knowledge, okay? In other words, we can find a cure for diabetes, and that's very difficult, time-consuming, tedious. But then you think about how do you get that treatment to every single person who needs it every time the right way. And you have a whole nother challenge, okay? That's the difference between research and quality improvement. So we know that a lot of things are good for patients. We don't consistently apply them. They're difficult. We've known that washing our hands is a really good idea. Okay, what job description in the hospital washes their hands most consistently and hits 99%? What job description? Yeah, food service and? Yep, housekeeping. Okay, who's the worst? Absolutely, we're terrible. And we know this information. We know Semmelweis, 1846, childbed fever. Okay, once we started washing hands, that 40% mortality rate dropped, okay, in a really impressive way. Current hand washing rates among healthcare providers is about 50%. Okay, that's us. Aspirin after myocardial infarction, we've known for a long time that that's very good. About 10 years ago, we weren't doing a very good job. Now, 99.9%. Okay, why is that? It's all protocol driven. Okay, it's standardized. That process is standardized. I have to try as an internist really, really hard to discharge somebody not on aspirin. Okay, and I guarantee you I'd probably be stopped at the door by 4 or 5 people wanting to know why I didn't give that patient aspirin. Okay. So consistent application of what we know is difficult, and consistent application of best practice is really, really difficult. But there are some examples of success. The Michigan Keystone Initiative. Has anybody heard of this? Okay. Anybody heard of Atul Gawande, the Checklist Manifesto? Okay, really good book. Peter Pronovost, Atul Gawande, a lot of these sort of important people in quality improvement and patient safety started thinking about how we keep patients safe in the hospital. One initiative that came out of this was how we decrease central line infections. Okay. When I was a resident, we used to think that, you know, a central line infection was really just the cost of being sick. Okay, if you were in the ICU long enough, you were going to get a central line infection. Now we know that that's not true. There are many organizations that are incredibly busy who have 0 central line infections. Okay, and all of that was because of this. Peter Pronovost and the work that he did at Hopkins. His work was initially underappreciated. But he's the one we had to thank for all the barriers that we do and the checklist that we use to put in central lines. Basically what he did was, after he created this checklist and had some success in his own local environment, his institution didn't adopt his checklist. He kind of did a road show with this and caught the attention of the Michigan Hospital Association. They said, we're going to implement this statewide. Okay, so they took Peter Pronovost's checklist, used it in every ICU across Michigan. So big academic ICUs in Ann Arbor to very small 4-bed ICUs in rural Michigan. Okay, and what they came up with was this. They had a 66% reduction in central line infection rates in just 3 months. Their average ICU, which is probably fairly small, outperformed 90% of the nation's ICUs. Okay, so this was the Michigan Keystone Initiative was a really big boost for quality improvement, that if you standardize some processes and pay close attention to these things, you can actually have really strong patient outcomes, which is what we're really interested in. Other people have done similar things in terms of decreasing length of sedation in ICUs, and actually decreasing ventilator-associated pneumonias. But this is all hard work, okay? There's nothing easy about it, and part of it is, you know, it requires a lot of effort and it requires change, which is probably the most, the biggest barrier. If this were simple, all of these things would be true. I would never be late. If I could easily improve my performance, I would never be late. I would never be grumpy in the morning. No one would wait for medical care. Everyone would receive exactly the right care every time. Okay, but there are a lot of confounding barriers here. Probably the most important way to control for those variables and increase your success is to use a method. Okay, is to use a structure behind your effort. And two of the most common things are actually borrowed from business. Manufacturing has been doing this for a very long time. Medicine and healthcare in general is slow to adopt. We're going to talk about PDSA cycles, the IHI model for improvement. The IHI is the Institute for Healthcare Improvement. And we're going to talk about Six Sigma and Lean. So Walter Shoehart again. So the rest of his story is that he also had this theory about processes. And remember, he's a statistician. And he understood that when you look at manufacturing, if I'm making shoes, and I make 100 shoes a week, there's a pretty good chance that some of those shoes are going to be defective. Okay? And so if I have 1 week where I have 5 defective shoes, the next week I have 20 defective shoes, the third week I have 7 defective shoes, was I really awful the second week? Anybody know? What if I have a new boss? And the week that I have 5 shoes, he says, great job, that are defective. The second week, I have 20 defective shoes, and he says, you're fired. Brings in somebody else. Every process has an inherent defect rate. Okay? Every process has variability. Does that make sense? So there's going to be some amount of defects that I produce when I'm making my shoes. The only way you're going to know that is to measure over time, okay, and see what that defect rate is. And what you're looking for is something that stays within 3 standard deviations of the mean, okay? If every week my defect rate is within 3 standard deviations of my mean, my process is in control for the way I have the process currently designed. Does that make sense? Okay. So if my control limits, so the upper and lower end of that defect rate, so the lower end is 0 defects, maybe the upper end is 12 defects, okay? And that's within 3 standard deviations of my mean, okay? When I start to have days where I'm producing 20, 30, 40 defects, okay, then there's something going wrong in my process. So he was one of the first people to recognize this, okay? And he said that if you start to mess with processes that are in control, you're going to make them more out of control, okay? So if you think about an oscillating string, you know, we know this from physics, if you touch it, you're going to disrupt the oscillations and probably make them wilder. Make sense? Okay, so if you're messing with a process that's in control, it's called tampering. You're going to increase the variability within the process. Okay? If you leave it alone and only mess with those data points that are outside of control, then you're looking for assignable causes. Okay, you're looking for what was the reason she had 40 defects in a week? Okay, and you find out it's because I fell off the wagon and I'm drinking Budweiser with my lunch every day. Okay, you're looking for an assignable cause. But those weeks where I have 5 defects, you're not going to pay attention to those, okay? Because that's within control of the process. Does that make sense? Okay. What's the symbol for deviation in statistics? Sigma, okay? 3 standard deviations from the mean gives us how many sigmas? Like 3 on each side? 3 standard deviations of the mean? 6. This is 6 sigma, okay? This is where that comes from. The whole goal is to control a process within 3 standard deviations of the mean, okay? And that'll tell you if that process is in control or not. The whole idea here is to understand the characteristics of the process that you have. And it's sort of easy to think about that in terms of manufacturing. The control limits, or the 3 standard deviations that you get, may not be where you want the process to be, okay? Maybe as my new boss, you want my average defect rate, instead of 6, you want it to be 3, okay? And so what you're going to do is you're going to modify the process and then continue to measure to see if you've decreased the mean and have tightened those control limits. Okay, if now we have a new 3 standard deviation set, okay, new control limits. Does that make sense? But you have to have baseline measurements to know that first, and then move forward. And I'll show you an example of that. So he was the first guy to really show manufacturing that quality doesn't have to be the enemy of productivity. Okay, so the thinking was, you just crank out as much as you can, pick up the defects, scrap them, rerun them. Okay, that was sort of the way that we were doing manufacturing in the 1920s. Okay, he was the first guy to show that we can do higher quality of work and not decrease productivity. Okay, that there's loss in that rework. Okay. He and one of his peers at the time, Edward Deming, were actually recruited to Japan after World War II and are largely credited with rebuilding Toyota, okay, and Japanese manufacturing. You guys remember sort of in the 70s and 80s, Japan was blowing us away in terms of quality of manufacturing. They were doing a fantastic job, okay, and part of that was because of this methodology. Okay, and this thinking. Here in the States, we were still cranking out quantity over quality. Okay. So the model for improvement. So we've taken his thinking, okay, and are starting to use a lot of those concepts in medicine over the last 10 or 15 years. The Institute for Healthcare Improvement is probably the leader in this. Are you guys aware of that organization? Institute for Healthcare Improvement? IHI. They have the IHI Open School. If you guys have to give a talk, if you have to participate in a project, this is an online curriculum for quality improvement and patient safety. Okay, it's free for academic organizations, so it's a really great resource for you. It has all the links you would ever need. If you're looking for a conference to go to, the IHI is what you want to go to. Okay, so the Institute for Healthcare Improvement guides a lot of organizations. And what they did was they basically took Shoehart's PDSA cycle, Plan, Do, Study, Act, and they added 3 questions to the top of it. Okay, it now became their model for improvement. The first is, what are we trying to accomplish? The second is, how will we know the changes and improvements? And then what changes can we make that will result in an improvement? So an example is, if I'm in clinic and I want to decrease the number of walk-ins that we have, because walk-ins are incredibly disruptive. It pulls the nurses out of their workflow, and most of our clinics do have patients that will walk in, okay? Which is an interesting issue, because instead of having a process to handle that, we just let it continue to be very disruptive to us. Okay, so let's pretend that we're going to tackle this issue of walk-ins. If my goal is to decrease the number of walk-ins, and I put a sign on the door that says no more walk-ins, that's my intervention. Okay, how will I know in 2 weeks' time if I've made a difference or not? This is an easy one. Yeah, so what do you have to know beforehand? Yeah, your walk-in rate beforehand. Yeah, what has it been for the last month or so? Okay, that will give you some idea what your baseline is. And then you have to measure afterwards too. The whole point is, how do you know if a change is going to make an improvement or not? You have to measure, okay? You can't just change what you're doing and then get a feel for it later on, okay? If you really, and this is where people go wrong, okay? Because when we think about a problem, we often think of a lot of solutions. We're problem solvers, okay? We're pretty natural problem solvers. But the problem is we often don't take the time to get baseline data and data afterwards to really know if the effort that we're putting in is worth our investment, okay? And when you're starting to talk about modifying a process, okay, you're potentially interfering with many people's workflows. People don't like it, okay? And so you have to be able to show a return on their time invested and their effort invested. Measurement's the only way you're going to do that. And then what changes can we make that will result in an improvement? This is easy for us. We can come up with 10 ways to make things better most of the time, okay? And then you do plan, do, study, act. So the plan piece is you set the objective, you ask questions, make predictions, answer the questions, collect data to answer the question, sort of a baseline piece. Do, you actually carry out the plan. So the plan is I'm going to gather some baseline data. 2 weeks from now, I'm going to put a sign on the door that says absolutely no more walk-ins, okay? And in this plan part, you'll say whose job it is to put the sign out, whose job it is to make sure it's up every day, okay? Kind of the logistics of the intervention. And then you actually do it, okay? And you start collecting data. The study part is after you get the data, you interpret it, okay? And then the act piece is you either put that intervention into practice, into daily practice, or you plan for the next cycle. Like this. So what we're basically doing is we're moving from hunches, theories, predictions, ideas, to actually changes that result in an improvement. So let's say that we do this, and our first run, our baseline data is we have 10 walk-ins a week, okay? And so we put the sign up. After we've had the sign up for a week, we get 5 walk-ins a week, okay? We had some improvement, but we're not to zero where we want to be. And so we get together and we think about it and we realize that, you know, that sign that we put out is white just like every other sign that's on the door or on the windows or every other sign that's presented to a patient. So we decided to make the sign hot pink, okay? And so then that would be the second PDSA cycle, okay, is using this hot pink sign, measuring the effect. And then we find that we have 1 walk-in a week. And so then what you've created now is a new process, okay? You've moved from one number to another number to another number. And then at some point you have to decide where you want that process to be, okay? Is 1 walk-in a week okay? Plus minus 3 standard deviations? Maybe. If that's okay, then you're done. If it's not where you want the process to be, then you move forward, okay? Any questions about that? No? Okay. Let's talk about this methodology. 6 sigma, 3 standard deviations from the mean on each side, okay? And if you turn that graph the other way, it's typically a normal distribution of data, okay? So 6 sigma builds upon Walter Shoehart's ideas and was actually something that Motorola expanded upon in the 80s. And so their CEO at that time is credited with Six Sigma, and that's methodology in business. And this stuff is all over the place in the business world. If you Google Six Sigma on Amazon, it's all business literature, okay? They're all business books, and you'll get 100,000 hits. So Six Sigma uses a process called DMAIC as the backbone. So it's define, measure, analyze, improve, and control. And we've moved from using PDSA cycles in medicine to using this structure now. The reason why I like it is because it's a little more explicit at each step. The define, you really look at sort of what is the problem and what is your current process. Measure and analyze are a little more explicit in terms of getting that baseline information. For example, we're looking at our high utilizers in general medicine. So we're looking at those patients that are our primary care clinic patients that utilize the ER heavily. Okay, so we took our top, 15 patients that go to the ER a lot. For the number one patient in 1 year, I reviewed 96 visits, okay? 96 visits, 2 of them were hospitalizations. A handful of those were clinic visits, which the patient always showed up for, okay? And the rest of those were all ER visits. And so, we can think of a lot of ways to intervene upon those patients. But the problem is we didn't really understand who those patients were, okay? We had a lot of guesses, and a lot of those guesses were very biased. And so, what we found in reviewing the charts of these patients was that they're not all drug seekers, and they're not all mentally ill, okay? They have other confounding variables that we can impact in a different way. So our potential intervention for those patients is going to be very different than what we thought about at the very beginning, okay? And part of that is because we measured extensively at the beginning, okay, and got as much information about the process and the patients and the people that we could before we moved to improving the process or intervening, okay? The control piece is once you've created an intervention that works, okay, like our pink sign works, you have to control the process. So you have to have a plan in place for how that's going to continue in perpetuity, okay? So you have to say that, the front desk people, it's going to be your job for this sign to be out every Monday, okay? And every month we're going to do an audit to make sure that that sign is still out, okay? So that's the control plan. Make sense? Okay. This isn't rocket science, right? If business folks can do it, we can do it. So this is just some information about Six Sigma. Whichever methodology you use, however, the plan is basically the same. You're going to innovate, you're going to create a pilot, implement, and then you're going to spread. Okay? So after the pilot, if it works, you're going to implement in a big way, and then you're going to spread it across the organization. Innovation's easy. This is hard. Okay? So deciding what to innovate. There are a lot of ways to find targets of projects. Okay? You can reflect upon problems in the system. Okay? You can react to a bad event. Okay? You can go to the front line and ask people what makes their day inefficient or what drives them crazy. You can go to the front line and ask providers, what's the next thing that's going to harm a patient? Okay? And those start to become your targets. You can benchmark. Okay? So what is our aspirin rate after MI? And we're getting a lot of benchmarking data now because we're doing a lot of reporting. And if everybody else in the world is, 90% and we're 80, we've got work to do. Okay? So basically you're looking for these areas of gaps that you can target to more consistently apply best practice or process. Sometimes thinking creatively, and there are a lot of exercises to do this. If you could design the perfect system to, turn over ORs between cases, what would it look like? What would that process look like? How quickly would it happen? Who would be involved? If you had unlimited resources, how would you do it? How would you design it? And sometimes that gets us thinking outside the box, and actually comes up with solutions that are very possible. These pieces are part of the lean methodology. Okay, so the Lean Six Sigma, you'll often hear those things sort of jammed together. Six Sigma is really the DMAIC piece is how we produce a system change. Lean is how you pull waste out of a system and inefficiencies out of a system. And these are some things to think about when you're doing that. So regardless what you use, change is going to be required. It's not easy. So why don't people change? What's the problem? What's hard about that? Anybody have children? Anybody? Nobody? Yeah, maybe? Okay. All right. I have a 3-year-old. Change is really hard. Okay? So why don't people like to change? Why? Yeah, we like routine. Yeah. No matter what, how free-spirited you are, and, if you've done those personality tests and you're a red or whatever, no matter what a free spirit you are, we really still do crave some routine, especially when it comes to our work environment. Okay. What else? Yeah, people become scared of change. Yeah, you don't know how much more effort it's going to require on your part. Okay, you don't know how much more time it's going to require on your part. If you go to a residency meeting this afternoon and your program director says, "We're going to blow up all the rotations, and we're going to try this," your first reaction is probably not going to be awesome. It's going to be, "Oh my gosh, what's this going to do to my world?" Okay, we don't like to be messed with in that way. Autonomy is an issue. We don't like being told what to do either. We're pretty autonomous in medicine, okay? And so being reminded that we're part of a system and we're part of a structure is sometimes a little tough, okay? And that happens at all levels of healthcare. People become very autonomous in their daily work. Stability that comes with routine, we don't care. Program behavior that results from processes in a system. So we become sort of used to that, okay? We become used to the inherent rewards that are built into our structure, okay? And so if we change that structure, we are going to miss some of those things. Tunnel vision. We have a hard time seeing the system for our own daily work. Who thinks they're overworked and underpaid? Okay. If you walk around and you ask everybody you encounter, are you overworked and underpaid? You're not going to find anybody who says no. Okay. Everybody thinks they're overworked and underpaid. Okay. And everybody, there's also this phenomenon that sociologists have studied. Everybody thinks it's getting worse. Okay. If you listen to people talk, we work much harder than we did a couple of years ago. We're not getting paid as much as we did a couple of years ago, okay? It's always getting worse. People are underpaid, overworked, and it's getting worse. So we're very afraid of that. We're also afraid of this accumulation effect, okay? If you add one more thing to me, there's no way I'll be able to get my stuff done, okay? So, but some things really do catch on. So why do things catch on? Despite all of those barriers, why do things catch on? There's a really good book, Diffusion of Innovations, written by a sociologist, Everett Rogers. He was born and raised in Iowa, 1930s, I think. Dad was a really successful farmer, as are many people in Iowa. And his dad was a really savvy, sort of mechanically inclined guy. Okay, so anything new that sort of came on the market that was mechanical, that had to do with farming, he was on it, okay, and he was on it early. But in the late 1930s, we started using more biochemical modifications in farming, and his dad was incredibly resistant to that. Right around that time, the family lost their farm. There was a drought. They lost everything. And a lot of his peers were able to still produce some yield because they had adopted some of these biochemical modifications that were available in farming at that time. So it really impacted Everett Rogers at a young age. And he was really interested in what motivates people to accept new ideas. And his book was groundbreaking. And he coined a term that we hear often when it comes to technological advances: early adopters. Have you guys heard of early adopters of technology? Okay, it's in the press. It's sort of there, and we understand that concept. This comes from him. So he said that there are some reasons why ideas will catch on. They have a relative advantage compared to what was done previously. If you can demonstrate that advantage, then your idea is going to spread. Compatibility. So if you pitch an idea to somebody and they can see it fitting within their workflow, they're going to do it. Complexity or simplicity. The more complex it is, the less likely we are to adapt it. So make it simple, keep it simple. You're going to be more successful. Trialability, if people understand that I'm going to try this for a week, much more likely to adopt it. Okay. Observability. You have to be able to see the effect of what you're doing. This is the measurement piece. Okay. And there's also a social context that's incredibly important. And this is probably, if you're going to bend people to your will, kidding, if you're going to induce change within your organization, this is what you have to understand. That there are different rates of adoption of innovation. Okay. So these early adopters, are these people here on the left. Okay. On the far left, these people adopt really early, okay? These are the people that no matter what, if Apple says we're coming out with a new product tomorrow, they're camped out outside. They're there. They don't care what the product is. They want it. They need to be a part of it, okay? They want to be a part of whatever change is coming, okay? And there are people like this everywhere. Think about, in the surgical environment, if there's a new implant, I want to use it first, okay? These are these folks. There aren't very many of them, okay? But these are the people that you need to get on the bandwagon early, okay? You need to know who they are because that's who you're pitching to first. Opinion leaders are incredibly important because they're the people that if you look around your organization, they're the people whose opinions matter, okay? The early adopters, those innovators on the far left, the majority of the people are watching them thinking, I don't know, I think they're a little crazy, okay? The next wave are the people whose opinions everyone else respects, okay? So if I look around my group and I know that, some people are just overzealous and they're going to do anything. But then there's this group of people who I really, really have a lot of respect for. They do really, really good work. And if they're doing it, maybe I should think about doing it too. Okay? Opinion leaders. And then once these people catch on, then the majority come. Okay? There's sort of the early majority that's tied to that group. There's a late majority. And then these laggards are going to be the people who come on last. Okay? Where do you think they're going to get the best feedback on a process? What group of people are going to give you the best feedback and the most critical feedback of the process you're pitching or the idea that you're pitching? these guys. It's the grumblers, okay? You have to pay attention to them because they're going to give you fantastic feedback. They're going to give you an incredibly hard time, but that's what you want to really refine the process that you're working on. This is nobody with a marketing background. This is where a product becomes successful, okay? This is how you gain market share and saturate a market with a new idea. There's also this idea of personal change. Another way to think about it is that people sort of have a different freezing point and thawing point. Okay, this is just a more visual way of thinking about it, is that people are sort of frozen and fixed in their ideas. They have a different point at which they unfreeze, and then they will refreeze. Okay, so you sort of have this period of time, and you try to shift that to the left if you can. Knowing those things, there are strategies then that you can use to induce change, okay, and to have people be more accepting of your ideas. And that's really to anticipate all of those things that we mentioned. Identify the early adopters. Those are the people that you want on a committee, okay? You want an early adopter, and you want an opinion leader, okay? So you look around a group of providers, and you find out who's the most respected, okay? Who's gonna bring everybody else along, okay? So you want an overzealous person, and you want a good opinion leader on your team. And you want to respect the process. You want to understand what the barriers are to change a system and what the barriers are for personal change, and anticipate those and help, move people along. Maintaining transparency, reassurance, keeping things simple will all help you be more successful. So to sort of put all this together, any questions so far? No? Okay. So I'm going to show you an example, and then we'll be done. Okay, so this was a project that we did in general medicine, 2 years ago now. I met with the general internal medicine staff, and I said to them, so the nurses, the MAs, the front desk folks, what makes you crazy? Okay, what is it about your day that needs to be fixed? And they very quickly identified that they are just being killed with opioid refill requests. So we took a look at the process. And basically what happened was we had 12 general internists at the time, and we had 12 best practices for handling opioids, okay? And everybody insisted their process was the best, no doubt about it. So basically the way that this process happened was a refill was requested, and that was done in one of three ways. The patient called, they faxed, the pharmacy faxed, or the patient walked in demanding their opioid refill. The appropriateness was assessed, so the way that happened, or the things that went into that was, what was the reason for the opioid? Did they have a pain contract or an agreement? Were they part of a registry, the Illinois Prescription Monitoring Database? Did they violate any agreements that they had? When was the last visit? When was the last urine tox screen? And then if we felt that they were appropriate, then we filled the prescription. Pharmacy, pickup, we notified the patient. The problem is, that this was happening every 30 days for every single patient on recurring opioids. And so the nurses, we actually measured some baseline data, and we found that they were spending a third of their phone time on opioid refills. And so our advantage was nursing time. How do we create an advantage to get buy-in on this project? And it was, we can reduce the time that nursing is spent doing this. We also learned something else very interesting. There was this perception that we were on the brink of violence, okay, at our front desk because these patients were so demanding, security was coming all the time, and that the majority of our recurrent opioid prescriptions, those patients were problem patients. So basically what we did was every time security is called to the front desk, there's a record of it. I reviewed all the records. Security had come twice in the past year and a half. Okay, but the perception was that they're there once a week, which clearly wasn't the case. The other issue was we actually printed lists of every patient with a recurring opioid prescription, and we had the providers look at those patients and flag patients that they felt were sort of problematic or potentially abusing. It was the vast minority. Okay, the majority of our patients on recurring opioid prescriptions were stable, compliant patients. Okay, they weren't problem patients identified by nursing or physicians. Okay, so that gave us an idea for an intervention. I don't have to tell you this. This is a huge deal. Just as an anecdote, I was flying back from Hawaii last Friday night and actually got called, is there a physician on the plane? Big plane, I was the only physician on the plane. And I went up, and it was a young girl who was having a headache, who, after I talked with her and examined her and offered her some Tylenol and ibuprofen, asked me for Vicodin. Okay, so it happens at 30,000 feet as well, this problem. So basically, we reviewed best practices, reviewed current guidelines to see what we needed to be doing in terms of prescribing and managing chronic opioids. And these were sort of best practices. We created a team that was very multidisciplinary, nursing, pharmacy, IT. We had a really great group of people. And this was our mission statement and our aim statement. Our ultimate goal was to decrease the number of phone calls received and made by nursing, specifically addressing opioids, by 50%. Okay? And we were going to institute a proactive refill process. So so how will we know changes and improvement? We simply counted the number of phone calls that our nurses were getting. We did that very low tech, just a tally sheet by the phone, okay? And we collected the data weekly. The nurses were very invested, and they were getting me their sheets at the end of the week. They were really, really happy to do this. Our general medicine clinic is divided into 3 different teams of nurses and physicians, and we did this on one team initially. These were some of our other interventions, but we decided simply to go with proactive refills initially. So basically what we did was we focused on one team. We made a very big calendar. This was all done manually. And what we did was we reviewed that list of patients that were on recurring opioids. We identified the patients that we were comfortable refilling every month. They're getting filled every month anyway, okay? So we put them on automatic refills. So basically, the patients didn't have to call anymore, okay? Every month, we would just refill their opioids. And I called all of those patients myself and said, in our effort to provide better customer service to you, you don't have to call the clinic anymore for your opioid refills, okay? Patients were gracious. They were very happy. And basically what we found was this. These were our initial number of phone calls per week. This is what happened after we made our intervention, okay? So this was our mean of the process initially. This was the upper control limit, the lower control limit. This process was in control. There was only one point that fell out of control. Okay, so that's the 6 sigma, or the 3 standard deviations that we've mentioned earlier. After we did this process, these were our new control limits. See how much tighter these control limits are than this one? Okay, we've created a tighter process in the end. So that's an example. We had a 72% reduction in phone calls to and from the green team nurses. We had fantastic feedback from the nurses. We had the other 2 teams wanting to do the same thing. And I didn't tell them what we were doing. The word spread amongst the nursing staff that this is what happened on one team, and everybody else wanted to do it too. Okay? So that idea of sort of change spreading rapidly, okay? This is diffusion of innovation, okay? People were excited. The crux of this is, though, the really interesting piece is that we eliminated some phone calls, okay? But the nurses still had to figure out when the scripts were due, okay? Follow that on this calendar that we produce, and ultimately we produce an electronic solution to this. They still had to call these prescriptions into the pharmacy or get the script ready. And sometimes we're still checking back with the physician, okay? There was still a fair amount of work involved, though we eliminated some phone calls. The reason why this was successful is because it put the nurses in charge. It moved the work into a place where they could sort of control when it happened, and they weren't reacting to walk-ins and phone calls, okay? So all the phone calls that were being made sort of at their discretion and when they had time to do it, okay? So we sort of shifted work. There was still a fair amount of work that was happening. We didn't eliminate work. Does that make sense? It just integrated into their workflow much better. Incredibly happy with the process. Okay. And just all of these change ideas, we're doing all of these now. Okay. And we have a grant for patient education stuff, and we have a whole process on how we manage opioids now. So we didn't just tell patients not to call anymore, and we didn't just put everybody on recurring prescriptions. We now have a structure for when we do urine tox screens. We now have a structure for pill counts. We now have a structure for patient dismissal and termination for violating our agreements in clinics. So we've become much more proactive because we have time to move to concentrate those efforts instead of reacting to all of these phone calls. Does that make sense? Okay, we have a much more robust process now. So basically, I think that we hit these points. The difference between research and quality improvement, a couple of methodologies, PDSA and DMAIC or Six Sigma, and then change and how you can overcome barriers to change, and a good example of what we have done. So, any questions, comments? Okay, thank you. Any feedback that you have, please, on your sheets.